All right. I'd like to welcome everyone to the webinar series today. The webinar today is titled Expanding the Impact of Antimicrobial Stewardship with a Think Global Emphasis. And I'm really excited today. We've got two amazing speakers, Dr. Libby Dodds-Ashley, or Elizabeth Dodds-Ashley, Professor of Medicine, Infectious Diseases at Duke University, and then Dr. Arjun Srinivasan is Captain in the U.S. Public Health Services, Deputy Director for Program Improvement, Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. And this activity is being brought to you from the Center for Infectious Disease Research and Policy at the University of Minnesota. And also we worked in collaboration with the Society of Infectious Disease Pharmacists for this educational activity. So I'll get into that as well as all the CE that you'll be able to obtain depending on your professional affiliation. Just gonna move my slide forward. And I'm Marnie Peterson, and I'm the moderator today. So for disclosures, our first slide, as this is a CE activity, continuing educational activity, we worked with Pro-CE and Clinical Care Options, and they do require obviously all of the faculty, planners, managers to submit their financial relationships disclosures. And you can see below all of the members, whether they were faculty, planners, reviewers, or the Pro-CE staff, have no relevant financial relationships to disclose. And this is an educational activity, so we're going to discuss all kinds of material published. We may discuss some agents that are investigational use that's not indicated by the FDA. We're obviously not recommending the use of any agent outside of labeled indications. It is an educational activity, and we hope that you as participants use this newly acquired information to enhance your outcomes, whether it be for your patients or your own professional development. Target audience is all of you joining us today. It's designed to meet the educational needs of physicians, pharmacists, and laboratory professionals. Our learning objectives, as it pertains to our title of this global perspective, we're going to describe how diagnostics and clinical outcomes are being utilized to inform U.S. and international policies and deploy resources, how these diagnostic clinical outcomes are being utilized to allocate resources across health systems, and then review the similarities, differences in U.S. versus an example of a global surveillance program initiative, which Libby will be providing to us today. And thank you to our funding sponsor. The activity is supported by an educational grant from bioMérieux. A few more things for your CE. This is 1.25 hours of CE contact hours for pharmacists, ACPE, for the CME physicians, and for the clinical laboratory professionals PACE. So it's important that after this, viewing this live, that you go to proce.com. So this is the link. I will also put this in the chat box as this is all being cast to you from Zoom. And you'll be able to complete the online post-test and evaluation. The deadline for this live today activity is 1 month from now, October 21st. And then you'll be able to upload that if you're a pharmacist to the CPE monitor. There is a attendance code you're going to need, and we will be providing that to you at the end of the session. And before I turn it over to Dr. Srinivasan, or Captain Srinivasan, a couple other things. If you're just joining us, this is recorded. So you'll be able to view it at a later time as well, or share it with your colleagues. And there's a Q&A session to this. So it's not just presentation and then you're done. Please stay on for the Q&A session, provide questions, comments, information via the chat box or the Q&A box via the Zoom function. And then I'll be back on with you and our speakers to guide us through the Q&A session at the back end. So with that, that's all you need from me. I'm going to stop sharing my slides and invite Captain Srinivasan to present. And please let me know if you have any questions. Those that are listening, I can answer your questions through the chat box as well while our speakers are engaging with you.
Marnie, can you see that okay, the slides?
I can. You look
okay,
great,
perfect.
and I can see them and I can hear you well.
Excellent, thank you. Okay, so thank you to CIDRAP for putting on this webinar, and thank you to all of you for joining us today. I always want to begin every presentation that I do by acknowledging the fact that you all are incredibly busy doing a lot of very, very important things. And the fact that you are taking an hour and 15 minutes out of your day to hear what we have to say and to ask questions and interact with us, it is deeply meaningful to me that you are giving us this time. We respect it, and hopefully we'll provide you with the information that will be useful to you by the end of this session. So I'm going to talk a little bit about the big picture of antibiotic stewardship in the country, and I'll begin by giving you a status update on where we are, right? Every year we survey hospitals to find out how they are doing with implementing our core elements of hospital antibiotic stewardship. And this is a survey that's completed by over 5,000 acute care hospitals in the United States. And you can see that we have really made phenomenal progress in the United States in getting stewardship programs implemented in acute care hospitals. As of 2021, it's the most recent data that we have, 95% of hospitals in the United States had stewardship programs in place that, by their report, met all 7 of the CDC's core elements for hospital stewardship program. And if you look even deeper, even more beyond that, there are very few hospitals in the country that aren't doing something related to stewardship, right? If you look at the hospitals that have fewer than 4 of the core elements in place, there's only 46 hospitals in the entire country that have fewer than 4 of these core elements in place. So we have really, I think, transformed the landscape, the infrastructure necessary to improve antibiotic use. It's necessary, it's not sufficient. We know there's a lot more that goes into that, but having a program is certainly an incredibly important first step. And that success has been across the spectrum of all types of hospitals. And I've bolded critical access hospitals here. It's something that I'm extremely proud of what our colleagues in the critical access hospital space have been able to do. They were way behind the rest of the nation when we started measuring this. 20%, so they were 50% lower than the rest of the country in terms of how many hospitals had stewardship programs back in 2014. And if you look in 2021, they have almost completely closed that gap. They're close to 90% of critical access hospitals that have stewardship programs that meet all of the CDC core elements. So tremendous progress in stewardship programs. Just a map to show you kind of where we are as a country with this. You can see states way up in the high 90s, 100% in Arizona. So tremendous progress in that big picture of stewardship programs. Well, how did we get to this point from 41% to 95%? And I think it boils down at the highest level to programs, right? We needed programs. We had to define what those programs were. Programs have to implement practices, and we had to identify what those practices were, point people towards them, and then measure the impact of those practices, especially through antibiotic use, which I'll say more about. And then, of course, to get the programs and the practices that we need, policies are incredibly helpful, right? Regulatory policies, accreditation policies, both of which we now have from the Joint Commission and from the DNVGL on the accreditation side, and from CMS on the regulatory side on antibiotic stewardship programs, and some new requirements that I'll show you on antibiotic use reporting. So programs, practices, and policies. We are now at a state, 95% of hospitals have the core elements in place. That's amazing. We also know that that provides us the opportunity to think about what's next. Where do we go from here? And one of the things that we know is that not all stewardship interventions are created equal, right? We know that there's data showing us that some interventions are more successful than others. And there are also some practices that we know from experience that are more effective, more implementable. And we have a lot of experience with this. And so what we are trying to do is now begin saying, that's great, now we have the stewardship infrastructure that's built. Let's now begin focusing on the particular aspects of stewardship that we think are most effective based on the data, or most effective based on experience. In the 2019 core elements revision, you probably saw we did try to identify some priorities for implementation, and we are now kind of trying to lean in on promoting implementation of those priority elements. And we have been doing this in collaboration and in association with what the Joint Commission is doing, right? Because they are in the same boat. They had an accreditation, they have an accreditation standard for stewardship programs. And so we've been talking with them and they've been saying the same thing. You know, we've had our standard for a few years. What now? How do we get people to take those next steps with stewardship? And so they have released their revised accreditation standards. And we have also are going to be releasing, we have priority implementation approaches. And we were working with the field, able to identify priority implementation approaches in 6 of the 7 core elements. We didn't really find one in the education core element, but let me share with you what we did find in the other core elements. Leadership commitment. So here for the priority implementation is that the physician or the pharmacist has antibiotic stewardship responsibilities in their contract or job description. And we've heard, you know, over and over again, it's so important to really have that codified somewhere so that it's very clear. This isn't just something that somebody's doing on the side or doing because they like it. It is part of the day-to-day expectation of what that physician or pharmacist does. For accountability, what we are saying the priority is the facility has co-leaders, both a pharmacist and a physician responsible for antibiotic stewardship outcomes. I think, again, we know from experience that the co-led program is the best way to go. You need a pharmacist, you need a physician, and they need to work together as co-leaders of an effective stewardship program. For expertise, what we are saying is that for physicians, they've completed an ID fellowship or a certificate program or other coursework in antibiotic stewardship directly. For pharmacists, it's that they completed a PGY2 infectious disease residency and or fellowship, or again, completed a certificate program or other coursework specific to antibiotic stewardship. It's making sure that our stewardship workforce has the training and the knowledge that it needs to be most effective. For action, 3 priorities here. The first is the availability of facility or region-specific treatment guidelines. We know that so much of what we do in stewardship is driven from the guidelines, from our recommendations. Without those recommendations, it's very difficult to do things like these other recommendations of prospective audit or prior authorization. You need to have guidelines in place so that people understand how you want antibiotics used in your local context, taking into account resistance patterns in your area, your formulary, your patient population. So local guidelines. The other 2 priorities, one is the formal procedure for authorization for the stewardship team. So prior authorization, restriction of certain antibiotics before they can be dispensed, or prior prospective audit and feedback, right? A policy or a procedure for the stewardship team to review courses of therapy for specific agents and provide real-time feedback and recommendations. We do know both of these are the most evidence-based stewardship interventions. And we also know that, you know, of these 2, when they're put head to head, the prospective audit and feedback does come out a little bit on top in terms of which one of these is most effective, but we point to both of them because there is a body of evidence that both of these interventions are effective. You may do both, you may do one or the other, but we really want people to lean in on doing at least one of these. And finally, for tracking, we do recommend, we are encouraging hospitals to submit antibiotic use data to the National Healthcare Safety Network antimicrobial use option. We think that is an effective way to monitor, to benchmark your antibiotic use so that you can look to see if your interventions are successful and also look to see where there might be opportunities to improve use. Reporting, the stewardship program provides reports on antibiotic use to prescribers at least annually. in talking with the experts and with the community, they said, really that needs to be at least at a unit or service level. Putting out a report which summarizes antibiotic use at too high a level, like at the hospital level, that's not actionable to providers. What they really want is a unit level report or a service specific report so that they can at least get some sense of what's going on in their area, how they are prescribing, and how their peers are prescribing. Well, how are we doing with implementing these priority elements? We are able to track that in our Nhsn survey, and you can see we have pretty decent uptake of each of these individual elements, right? The lowest being the reporting, the reports that go out to people at 32%, but the others, in the 60-70 range. So that means that we're starting from a really good base upon which to build with implementation of all of these priority approaches. A small number currently have all 6 of them in place. You can see about 9% have all of them in place. But if you look at where we are, about 40% of facilities have 4 or 5 of the elements in place. So we're really in a pretty good shape. About half the country is at 4, 5, or 6. So again, we start from a really good position. That's even better than we were going back to 2014 when we started the overall core elements, where we were at 40% and we're able to get to 95%. So I have a lot of confidence that now that we've identified these priorities, we can begin moving people to these most effective stewardship implementation approaches. And these are very much in line with what the Joint Commission is recommending. They are leaning forward in some of these same places. For example, the action, their priorities and our priorities are very much in line. They also recommend reporting to the antibiotic use option. So I think you can see that there is synergy here, where the Joint Commission accreditation standards, the CDC priority implementation approaches for the core elements were very much aligned. We know that right now there are no requirements or incentives or penalties related to that priority implementations. We are simply pointing to the things that we think are more effective, have been demonstrated to be more effective when it comes to implementing stewardship programs. We know that simply stating this and moving people in this direction, it's not going to miraculously transform antibiotic use, but we view this as a next step on this long journey that we're taking towards optimizing antibiotic use for every patient in every acute care hospital. I'll turn and talk a little bit about antibiotic use reporting, because this is another area where we've seen some exciting developments, and there are some big picture changes that are coming. So the National Healthcare Safety Network Antibiotic Use Option, or Antimicrobial Use Option, is the way that people can electronically report antibiotic use from their hospitals and then receive benchmarks on their antibiotic use. So you can compare your use to what other hospitals like you are doing. We have about over 2,400 hospitals that have submitted data to Nhsn, their antibiotic use, from all 50 states, quite a range of bed sizes, including about over 200 critical access hospitals. So the uptake of this option has really been broad. There is no requirement for this right now. So this uptake really is driven by hospitals that see value. They want those antibiotic use benchmarks, and they know that this is a way that they can get that information. However, we've been talking about this for quite some time because people have said, mandatory reporting of the antibiotic use could be incredibly important, right? Because rather than give us just an idea of what's going on, it would give us the true national picture of hospital antibiotic use. It could help us see the uptake and use of new antibiotics. Those come online. And if we're able to pair it with resistance data, it could potentially provide some really important opportunities to explore and improve the use of antibiotics. And just a couple of examples, both from kind of an overuse and a patient safety perspective, right? So from a patient safety perspective, what if we have a new agent for CRE and we see that there's a hospital that's not using that agent or hardly ever using that agent, but they have a lot of CRE? from a safety perspective, that might prompt us to say, hey, you have a lot of CRAs. There's a reason, this drug has been shown to be incredibly effective for treating these infections. Is there a reason why you're not using this new drug? And from an overuse perspective, could we find hospitals where they're using a lot of this new CRE active agent, but they don't have any or very little CRE? So we see this as being important on both sides of this, overuse and patient safety. There are people who have said, well, maybe one way to incentivize this would be to say that, you, in order to get access to these new agents, you should report your data into Nhsn AU. The challenge, of course, is that there are other considerations, right? So in the past, reporting mandates have often been tied to a requirement for public reporting of the data or to some type of payment based on performance. And we know in the stewardship community that none of those things are really a good idea for antibiotic use data. Can the public really make use of antibiotic use data? Is that something that should be publicly reported? Does it help patients or providers to publicly report that type of data? Is it beneficial to link antibiotic use to payment? I would say no, not based on what we're able to do with things like risk adjustment right now in patient population. So for us, we view the antibiotic use data and our measures, our benchmark measures of antibiotic use, the standardized antimicrobial administration ratios, as quality improvement measures. And we think that this idea of mandatory reporting is absolutely the right discussion to be having. I gave a presentation on stewardship and antibiotic use reporting to a group of hospital CEOs once, and one of them pulled me aside and said, this is all great, it's very interesting, but at the end of the day, if you want something done, you have to either pay me to do it or make me do it. That is how things get done in healthcare. And now we have that for the antibiotic use option. So this is a very large inpatient prospective payment system rule that CMS published just a few weeks ago. I think August 10th is the date that the final rule was posted. The link is there for you. But what you will see here is that in this rule, CMS is now going to require that all acute care hospitals, including critical access hospitals, report both antibiotic use and antibiotic resistance data into the National Healthcare Safety Network. And this is the requirement here. The eligible hospital or critical access hospital is in active engagement with CDC to submit antibiotic use and resistance data for that electronic health record reporting period and gets a report from Nhsn indicating that they have been successful. This will be required under the promoting interoperability rule in order to satisfy the public health and clinical data exchange objective. So as part of promoting interoperability, hospitals have to comply with that rule in order to get the payments associated with the promoting interoperability system. And in order to meet that now, you must report antibiotic use and resistance data to CDC's Nhsn in order to get that additional payment. It will be a required measure beginning with the reporting period in calendar year 2024. So hospitals have a couple of years in order to get this reporting up and running, but starting in 2024, you not just have to show that you're making progress toward it, you must be reporting your data in order to get the payment for the promoting interoperability. And this, I think, will then begin to give us that ability to begin making those correlations of antibiotic use and resistance, as I mentioned earlier. And we already have some exploratory examples of how that could potentially be used. Right now, we do have quite a bit of data on Clostridioides difficile as an outcome that's reported into Nhsn. And so we did do an analysis using the antibiotic use data for agents used to treat C. diff, so mostly oral vancomycin, but also fidaxomicin, and compared that to the C. diff rates in these hospitals. And you can see there are some hospitals that they're shown in the red diamonds here. These are hospitals that are using significant amounts. They have some of the highest use rates of days of therapy for oral vancomycin, but have very low rates of C. diff, right? So this is an example of how you can begin to think about mismatches in antibiotic use and some sort of an outcome, in this case C. diff, but you could also do it for resistance. It doesn't mean those hospitals are doing anything wrong. It could be that they get lots of patients from a nursing home and the patients are diagnosed elsewhere and then transferred with a diagnosis. So there certainly could be explanations for why this is the case, but it should prompt us to at least ask the question, this is a significant outlier. Why is that? Let's say close by saying just a few words about some of the things that are coming soon into the antibiotic use option. You know, as its use expands, we are working to make that option as usable as possible in order to inform your stewardship efforts. One of the things that people have told us is like, you know, we want to set goals for ourselves. We want to lower our ratios and we want to set a goal, but it would be helpful for us if you could tell us, like, if we set a goal to go from 1.1 to 0.9, how many days of therapy would we need to eliminate in order to get to that goal? So we have a feature in Nhsn called the Targeted Assessment for Stewardship that's currently in the application. It has already gone live. We are working on a user guide to talk a little bit more about it, but that's exactly what this does. You can enter a target and you can see translated into days of therapy, what's the difference between what you're using now and what your target is. We're continuing to work on risk adjustment. That is obviously, you know, a big and important issue for any sort of comparisons that we make in healthcare. And in the National Healthcare Safety Network, many of you probably know, we are able to risk adjust based on facility level characteristics. And people always ask, well, you know, what about the patient level characteristics? I have a lot of oncology patients, so my use is higher. Could we adjust for that in order to make the comparisons more powerful? So we have been working on this with lots of different partners, trying to understand, you know, how much would that patient level data improve risk adjustment, and what patient level data would be most useful for that adjustment? What's the smallest amount of data that we can collect in order to improve that type of risk adjustment? So lots of explorations of that currently ongoing. One of the issues, of course, is that, you know, risk adjustment it's really critical. If you're publicly reporting, if you're ranking, if you're paying. Right now, we're not doing any of that with Nhsn AU. So on one hand, I think you can make a case that, you know, the risk adjustment that we currently have is pretty good. There have been some studies showing that it's pretty good and it's useful for quality improvement purposes. But we also know, even for quality improvement, what we want is people focused on the areas where there are the most significant opportunities to improve use. And so clearly the risk adjustment work is a priority for us, because we know the better we can risk adjust, the better we can help you direct your efforts to those areas where there might be meaningful opportunities to improve use, rather than that difference in use simply being explained by a patient mix. We know that the only way we're going to be able to do this is through electronic reporting. People can't manually report all of this type of patient level information to us, and Nhsn is on the forefront of electronic data capture for this type of information. So much more to come on this, but this is an important direction for us. And finally, our state colleagues, our state health departments are getting more and more engaged on working on hospital antibiotic use, including stewardship in hospitals, antibiotic use reporting in hospitals. We were able to give our state health departments some expanded funding as part of the American Rescue Plan. And with that funding, more than 20 states have said that they are going to focus some of their efforts on expanding enrollment in Nhsn and creating groups to share the hospital use data, to start interacting with that data and discussing as a group how they can use the antibiotic use data to make improvements. Minnesota has done some amazing work in this area. And if you are not connected with your state healthcare associated infections and antibiotic resistance program about what you're doing and about what they are thinking with respect to stewardship in your state, I would urge you to do so. And there's a link here with contact information for all of those state programs. I'm going to close by just saying I think it is incredible that despite what's happened in the last 2 years, we are still seeing advances in stewardship. More hospitals have stewardship programs now than before the start of the pandemic, and that's incredible. There are a lot of new developments when you think about the big picture, right? Advancing standards, AU reporting requirements, and all of that is a reflection of the progress that we've made. And so the big picture, we are advancing stewardship, but it's think globally and act locally, right? Because none of what we're doing makes any difference if it doesn't translate into actions and things that support your important efforts. So all of what we do is intended to try and facilitate the actual important work that you do day in and day out. We are deeply appreciative of all that you do to protect patients by improving antibiotic use, and we are always eager to learn what more we can do to support those efforts. And with that, I am going to close my presentation and turn things either Marnie back over to you or over to Libby.
Yes, I'm going to welcome Libby, but Arjun, I want to thank you for your presentation. As Libby comes on, Dr. Elizabeth Dodds-Ashley is coming on and will begin sharing her slides. Arjun, I want to direct you to, there's quite a few questions that came in through the Q&A chat. If you can review those as well, they'll be helpful and we'll be able to address those during our Q&A session. There's some very good questions that came in during your presentation. So with that, would like to welcome Dr. Libby Dodds-Ashley, expanding the impact of antimicrobial stewardship, think global, and she's going to discuss all of her involvement and efforts in stewardship, both within her health system, but also globally with partnerships. So Libby, thank you for joining us today and taking the time. As Arjun said, we know you're all very busy, and I will turn over to you.
Thank you. Are you able to see my slides?
Yes.
Great.
And we hear you well.
Wonderful. Well, thank you, everyone. I want to echo Arjun's thanks for taking time out. I think this is such an important issue. And today we're going to pivot a little bit. And what I hope to do in the time we have together is to show you how a lot of these efforts that you've heard great progress on in the United States have been pivoted, expanded, and assimilated to help tackle the problem of antimicrobial resistance from the global perspective. So truly worldwide efforts by various groups who've done a lot of work in that arena to try to further our important response to the new pandemic of antimicrobial resistance. I want to start right where Dr. Srinivasan did, with the core elements for antibiotic stewardship programs in hospitals. So on the right-hand side of this slide, what you will see is the graphic from the CDC's core elements and how they guide antimicrobial stewardship programs in hospitals. And you've seen today how these have seen great uptake since first tracking in the Nhsn annual survey. Well, similarly, a few years ago, a group got together to create a corollary document that looked at global hospital antimicrobial stewardship core elements. And those are what you see depicted on the left. Very similar. They chose a slightly different order than the US CDC, but this was a consensus group that included Dr. Srinivasan in it to help come up with this, to help our global partners as they organize their antimicrobial stewardship work. And you can see here very similar elements. Essentially identical to what we're trying to do. So there really is global harmonization on how our antimicrobial stewardship programs need to perform in our hospitals to optimize antibiotic use, which is an exciting step forward as we try to frame some of that work. Now, there are also lots of toolkits available, similar to what has been made available by the US CDC for our US hospitals. The World Health Organization has been a big partner in this work, and they are informed by ongoing work of the US CDC as well as other groups, and I'll go into some of that. But they have this fairly recent practical toolkit on implementing stewardship in healthcare facilities in low and middle income countries. So areas with different resources and how those core elements might be adapted. This guidance document is very similar to some of the CDC guidance on how to implement stewardship in critical access hospitals or low resource settings, and can really give some guidance. And it includes some important assessment tools. So they have the ability to assess the core elements at the national level, and they also have the ability to do a tool at the facility level. These are exciting tools that are available on the WHO website. You can see the link there. at the bottom of this slide. And these are the forming the basis of some important work that the CDC and others are doing to try to investigate how assessing stewardship globally will look. It's probably a little bit different. It's actually some work that we're a part of here in Nhsn, and it's quite interesting as we work with different regions of the world to look at differences in antimicrobial stewardship, as well as differences in antibiotic access that really drive how we respond from a stewardship perspective. One of the most common, of course, being access to antibiotics on the commercial market without prescription or healthcare provider involvement per se, which can really introduce some interesting challenges in how we try to steward our antibiotics in those areas. Now, you've seen a lot of great data on our progress and how Arjun can drill in with the CDC colleagues on various core elements, on seeing what types of hospitals are there. We aren't quite there yet at the global level, but we do have some tools and have come a long way in the last 5 to 7 years at having some peeks at how we're doing about antibiotic stewardship and antimicrobial resistance. And I just want to give you a few of these. I'm going to show you some dashboards. Admittedly, I've just taken representative countries or regions just in the interest of time, but there are much more comprehensive data available if you dig into these in areas where you have interest. One of these is put out by the CDDEP, the Center for Disease Dynamics, Economics, and Policy. They issued an initial report on the state of the world's antibiotics in 2015, and they followed that up in 2021. And they looked at several different aspects of infectious diseases treatment and antimicrobial resistance response in these countries. They looked at policy indicators. So where were you with a roadmap for AMR? They looked at actual data on resistance in both humans and animals. They have antibiotic consumption data for humans and animals where available. And then they also have vaccination rates. They have data on availability of providers, as well as expenditures per capita. And I'll talk a little bit as I go through these examples. The data sources that are used for this are varied. And in this report from 2021, they are able to have a dashboard for 40 different countries that are included there. And for the interest of demonstration, I'll show you dashboards from the United States and Vietnam. Vietnam is actually where the Nhsn group does most of our international stewardship work, as well as their affiliates with Oxford that are over in that region. And so you can see here that they look at specific policy indicators, the first of which is enrollment in what they call GLASS. I'll talk more about this in a minute, but GLASS is the Global Antimicrobial Resistance Surveillance System. It is a worldwide monitoring system. Again, we'll go into further detail, so stay tuned on that because it's quite interesting. There's also looking at things like, is there a national action plan on AMR that is published and available? Do they have antimicrobial use surveillance possible in humans and animals, whether you can track cultures in humans and animals? And that is present actually, except for enrollment in GLASS for both the US and Vietnam, according to this most recent assessment. They also look at key indicators of resistance. They look at MRSA, CRE, ESBLs, as well as others, and have calculated a novel drug resistance index based on some of the data that they are able to acquire. It's not always available, as you can see here for Vietnam and humans. That is not reported because it was not available from the data sources that they have. So some metrics that we can look at and track. The plan is to continue this longitudinally so you can look at it with time. So certainly is an area of great interest. They also drill down to look at antibiotic use. They use defined daily doses as their antibiotic metric. And I think that this is important. They track it with time. So here you have data from 2010 through 2020 to show the change in use per million population. Now, you may look at this and say, gosh, this seems incredible data. I do want to highlight just a few caveats. One is, in order to receive these data from such a diverse geographic area, there are multiple data sources that are accepted. So for some countries, this is human use. In some countries, this is human purchases. It just depends. Same for the agricultural metrics that are there. But it's an important first step. You know, Arjun mentioned in his talk about how we are taking the next step on a long road. And I consider this an early step on a very important long road to having worldwide statistics in our antibiotic use and our resistance mechanisms, which is just so important for us to have. So this gives you a quick picture of this. Now, some of these data you can look at and actually manipulate in a more direct fashion, if you go to the website resistance map, that is the CDC data. So I'm sorry, the CDDEP data source that they used for a lot of this work. They have public facing data through 2015. And many of you may have used this as part of some of your COVID tracking work in recent years, because they also built up quite a robust COVID model. But so that is one source, but let's shift and talk about the World Health Organization's efforts to have more worldwide tracking, which is that GLASS system that we talked about. Again, Global Antimicrobial Resistance and Use Surveillance System, or GLASS. Here you see the worldwide map. Blue indicates countries that are enrolled in both AMR and AMC, so resistance and consumption modules. Purple is enrolled in AMR. Yellow is just the consumption. There's only one country that has that. And then gray are those not yet enrolled. So this is certainly at an early stage. The GLASS system was just launched in 2015, but it's already making a big impact on the ability to get data from many regions of the world. Now, I will say that for the CDDEP report, you were counted as fully enrolled in the GLASS system if you had at least submitted a plan to enroll and report your data. So that's where you may see some discrepancies if you look at this slide. As you might remember, that the United States had fully enrolled in GLASS per their metric, and Vietnam on this report has the same purple color. But the real issue there has to do with the reporting plan for both action elements. So just an important point to bring out there. So very helpful. They publish a report on GLASS each year, so you can track the progress of enrollment. And then they also give you peeks and looks into the various data elements that they have, which includes their AMR data. So they have resistance data for targeted pathogens from various infection sites. One thing you'll notice here, and impressed upon me initially, is the total number of infections shows that is not yet fully receiving reports globally. If you take a look at these, some of these look similar to numbers that we see in our DICOM network, our infection control network here at Duke, but very granular data on resistance trends, causative pathogens that are happening in different settings. So community settings, hospital settings, or if it's unknown. Very helpful, again, is that as we start to accrue these data and can track them with time. And I bring it here today just so that you can start have an idea. If you're looking for additional data sets, this is something the US participates in. And we'll be reporting more of that AR data into the system once we have the full reporting up and running that Arjun talked about through the most recent CMS mandates. Other data that we have on consumption, it comes from different sources there. Now, I said it could be consumption or purchases. There's a lot of data from the European CDC. This is a fun place for you to look if you have not. This is called their Esac Net Database, and you can log on to this website. It's provided there on this slide, and you can see rates of use quite granularly by country. Again, slightly different data sources sometimes. You can categorize this out. This was for antibacterials for systemic use in the hospital sector. You can also look at the community sector. You can look at antifungal drug use and get reports on how those look and different rates, with each color, with red being the highest rates of use per 1,000 inhabitants. This is all done similar to some prior data on just the global populations, just like that CDDEP report I showed. So also interesting, this is a great website. I actually use this tool a lot to look at how we're doing compared to others. And I will say that when I started doing international stewardship work, one thing I've noticed is I always felt when I look at this from the European CDC, which was available before we had our Nhsn system, I used to sort of wish we had these or feel that others were further ahead. But when I meet colleagues from these countries, including the ones on this slide that have green and some of the lowest rates of use, they always wish for our data set of having consistent data from our hospitals. It's all captured in the same way. So it's very interesting. Don't let any of this get you discouraged. I think everyone is on this long road to optimal stewardship, but everyone's making great progress. But we have lots of tools now where we can compare and contrast the various efforts of our groups going forward. And I think it's important that we think about these global issues because AMR is truly a global concern. Now, I want to shift gears. One thing that wasn't mentioned in the previous talk is we have some point prevalence surveys. So I think any pharmacy resident probably gets a little pang in their stomach when they hear about point prevalence surveys. These are day-long, typically, events where you go into a facility and we're going to review. I know I started my first ones here at Duke, and it seemed like we were always looking at Pip/Tazo. We're going to go review every patient on Pip/Tazo in the whole hospital. And those are still very useful tools that we do today. The CDC actually leads efforts on this. And has conducted a series of these in 2011 and then followed up in 2015, where they go in and review use in US hospitals. And this is really where we get our data on appropriateness of antibiotic use beyond the consumption data we have in the Nhsn AU option. So these are two relatively recent publications on the most recent iteration of this that looked at antibiotic use specifically for community-acquired pneumonia, looked at vancomycin use, looked at fluoroquinolone use. So some great data here on appropriateness. But that's really the US perspective, right? Is there a tool globally? And in fact, there is. It's called the Global PPS, and this is available to anyone worldwide. It's run out of the University of Antwerp in Belgium, but it has several partners, including some industry sponsorship that allows it to have this robust tool. We learned about this from our Vietnamese partners who taught us this is how they do their tracking of antibiotic use and how they've gotten some robust data. So their method is you go into the hospital of interest, and it is a one-day PPS activity. It's sort of rolling on the day you choose to do it. Their methods are that what you do is you identify every patient at 8 a.m. who is receiving an active or ongoing prescription for antibiotics at that time. There are two ways to do the data collection. Kind of more to the left is the ward form, and this is a paper form that you can print out. There are many options there. It's a very comprehensive form. There's also an online portal, which you see here, the data entry environment. So you can go out and have an electronic deployment of this if that's easier way to capture the data. But they've been doing this now for several years, and several hospitals, including the ones we work with in Vietnam, have done this serially, which allows them to track use with time. And there are beginning to emerge several publications that start to show the data that is possible. And I just have a few to share with you here. The first was published late last year, and it shows the point prevalence survey results for all of Canada. And I find it really interesting. The authors of this decided to break up the antibiotic use by community-acquired infections versus healthcare-acquired infections to show where there were differences. Fortunately, more piperacillin tazobactam in those in healthcare depicted in green, but it really allows you, when you can get these data on a standardized data collection form for an entire country, the things that you can do. And it also allows us to get a little bit faster to stewardship. There are some similar tools for targeted disease states on the CDC website. And I find that tools like this are so helpful because if we can just agree we're going to use the method that's out there, it can help all of us get to faster data. We don't spend quite as much time in committee trying to discern between different elements that we want to have captured. So this is one tool. It can be used in any country. So these are results from Ghana, where they were able to look across the country to describe antimicrobial use in hospitalized patients. So very useful, and it's a tool that allows us to compare. And eventually we should be able to compare use across countries as well, which is really exciting. This is a easy to use format. They have existing IRB approvals centrally. You can also get information on how to get IRB approval locally off their website. So I encourage all of you to take a look if you're interested in this. It is a very interesting tool as we've gone forward with some international stewardship work that got us very quickly to something that would have taken us 6 months in committee here locally. So pretty interesting and exciting work that's out there. And then you also have access to your data to help describe it. So this is just a small sample of publications. They actually have an email subscription service that you can get on their newsletter, and it is incredibly impressive the amount of work that they do every month and the dissemination of these results that they have. So that has been a quick review of some of the global surveillance that we have available for antibiotic use and antimicrobial resistance. It is admittedly early on, but it has come so far since the inception of these projects, all since 2015, essentially. These efforts are complementary and typically inclusive of what's going on in the United States. So they are not redundant. They are actually inclusive and helpful, and they will help move us all forward in our mission to track and hopefully quell antimicrobial resistance. So there are tools available for worldwide stewards that you can also use locally if there's interest. And so we just wanted to highlight some of those and make them available to you. I want to thank everyone for their time again, and hopefully bring everybody back so that we can have some questions.
Excellent, Libby. What a nice review of what's going on. You very much, Arjun, explained all the efforts that have been going on the last 8 years with the core elements in the US, and then how that has, the efforts that are going on globally. Arjun, did you have some time to look through the Q&A questions as well? Libby, I'll let you look at those as well, but there's some great questions there.
Yeah, I did. Do you want me to just kind of walk down?
Yeah, sure. If you want
okay,
to.
Sure.
Yeah, and then I'll elaborate a few that I had myself. But yes, please.
Okay,
there's some
excellent.
in there that are really good and burning, and I think all would have the same question.
Yeah. So a question about prospective audit and feedback. How often should it be done? There aren't firm, fast rules here. I would ask Libby to comment as well. Generally we tell people, yeah, at that kind of 2 to 3 day mark is a good time to do it, because it happens to be when culture results are probably back. So that's a great time to do kind of that initial review and see if you can figure out, like, there's culture results back. You probably got a diagnosis at that point. So can you pick the right agent and specify a duration of therapy? There are places that probably do it more frequently. Maybe some places have resources to do it every day, do it every 3 days. So no firm, fast rules here. I think it depends on what you're able to do. The most important thing, I think, though, is at least to do it once at that kind of 2-3 day-ish mark. Libby, what do you usually tell people who are asking you about prospective audit and feedback?
Yeah, we get this question all the time. And I think, honestly, you have to look at what your diagnostic capabilities are. So nothing is more frustrating as stewards to sit and have somebody be like, I reviewed every patient on meropenem at 72 hours. And we're like, well, you have a send out microbiology laboratory, so you don't get any results until 96 hours. So maybe we should move that out a little bit so we actually have data, as you suggested, Arjun. So really, it's very much, the answer is you should review them when you will have something that will drive a change, because it's not necessarily the best use of anyone's time to do it before that.
Yeah. Another great question here on the rationale for benchmarking. So right now, the benchmark year for Nhsn is 2017, right? And so the question is, why is it 2017, and when will it be updated, and how frequently will it be updated? And this is always, Libby's smiling, because this is always a question that comes up, and it's a challenge that we have, right? So in order to assess progress over time, you have to have a fixed benchmark, right? Because if you're looking to improve use over time, you want to have a benchmark against which to compare, to be able to say, we implemented an intervention for community-acquired pneumonia. Did our antibiotic use change since the time that we implemented that intervention? So, if we re-benchmark, the question is, could we re-benchmark every quarter? In theory, you could, but then you wouldn't be able to compare, and you wouldn't know if you're making progress against where you started. Even if you did it every year, right, you wouldn't be able to compare that benchmark. So how frequently to re-baseline is always a question. One of the options that we've explored, and I think we could we hold a baseline and do a new baseline? So, right, so could you hold a past baseline in place so that I could compare against that, but also provide me a new baseline? So I think there are lots of options that we have on the table and are exploring for rebaselining the data. And those are kind of the trade-offs that we consider. And Libby, you want to add something there?
Yeah, I just want to jump in and say, but there's a great tool out there if you really want to know what's changing year to year in the antibiotic use rates at your hospitals. Every year the CDC puts out the antibiotic use report. It's an annual report. And in the one that was released for 2020, it was released in November 2021, it has a great new tool, and it has quarterly distributions of the pooled mean SAR. So if you want to know, gosh, I was on a call, this is no joke, this morning, we have a unit that had a SAR of 9. It's like, right. But we went and looked, and the pooled mean rate is 2. So it's not as bad as we thought it was. And sometimes, and we just had a call with our team earlier this week, our goal isn't 1. And if you want help sort of figuring out what those average SARs are for hospital unit types, it's all in that 2020 report. It's one of my favorite stewardship tools of the past year. So I just wanted to highlight it here.
Yeah, no, that's awesome, Libby. Thank you. That is a great resource, and we do that report every year. So it has use rates. It also has breakdowns by agent type, so you can look and see what people are using within each of those categories. So lots and lots of data in there.
Yeah, and you also can get your percentile now in the SAR
Correct.
reports, right? In the Nhsn
right.
output, when you look by location. So the last column has been added recently, and it gives you where your SAR is, what percentile it is compared to those mean rates if you don't want to have to combine the two reports.
That's right. Another great question about whether or not the antibiotic use option or the SAR, does it explain inappropriate use? And it doesn't. The SAR is purely, and this is a great question, the SAR is purely a measure of amount of use, and it's a benchmark of your amount of use compared to other hospitals that are similar to yours with respect to teaching type, bed size, number of ICU beds. But it doesn't tell you that if you have more use, it doesn't mean your use is necessarily inappropriate. If you have less use, it doesn't necessarily mean that your use is better. It's merely intended to help you understand where there are differences between how much you're using and how much other people are using, to give you those, help you prioritize. You know, like Libby said, if there's a unit with a SAR of 9, well, that might be a place to say that seems high. Maybe we should go and look, and it may be fine. It may be completely appropriate. Maybe it's a teeny tiny unit, and they had one patient who was there for a very long time. So there are certainly reasons. It's intended to guide explorations. It doesn't tell you that use is good or bad. There's a question about reporting. Go ahead.
No, Arjun, did you see the question too around, it was one of the first questions that came in, but there's the antibiotic use requirement in more the acute care type hospitals, but where is it down your priority at some point that you get engaging more with the long-term acute care?
Yeah, absolutely. You know, we would love to see the AU reporting expand to other healthcare settings. The challenge in that space, of course, is that in the long-term care space, they are not as robust in terms of their electronic data infrastructure, right? So in order to submit to the antibiotic use option, you have to have an electronic medication administration record, or you have to have medication barcoding, and you have to have an electronic admissions discharge transfer system. I think that infrastructure and capacity is growing in the long-term care sector, and so that's absolutely a priority for us down the road. We're not quite there yet, but I suspect we will be before too very long.
I think you had a question you wanted to address.
You know, there's one about AR reporting, and of course we talked about that. The new requirement is for both AU and AR because we think that that's really important. A question about, does the SAR data change as more hospitals come in? Absolutely. The more hospitals that report, the better the benchmarks can be, because we have more facilities against which to benchmark. And so that's why we've been, you know, so really encouraging participation. And that's why, you know, this change for required reporting is going to be a really transformative event. And then a question about the software companies and to, you know, compel them to connect to Nhsn, AUR. You know, most of them already do. Right. So they have already seen that this is something that is value to their customers. Now it's going to be a requirement. So I know that groups like, you know, the big ones, Epic and Cerner and Meditech, they all have the functionality to do that reporting. There are many others that have it as well. And, you know, now that it's a requirement, I suspect all of them will be moving into the space to require that. Let's see.
Another question.
Yeah, go ahead.
Another question that I saw is, all right, I'm on, okay, good. I'm not on mute. Is there any discussion looking for correlations between CDC Community Vulnerability Index and the Nhsn AUR data?
Yeah, hey, Elizabeth, great question. And yes, so health disparity is a hugely important topic across the board here at CDC. And so we are beginning to look at the Nhsn data across all the domains, right? Antibiotic use, also the healthcare associated infections, begin looking at how that data is different based on things like social vulnerability indexes, area deprivation indices. You know, there are a lot of different indices that measure, or at least attempt to measure these types of disparities. And so we are in early stages yet of exploring how those can be brought into the NHSN data and how they might help us guide efforts to support areas where more might be needed. So it's a great question and a really active area of exploration for us.
Yeah. I have a question that was also submitted. Great questions that everyone's submitting today, by the way. Libby, how reliable do you think the WHO data? Did you see that question that's being reported when there's low resource settings? But you could also flip it to the other side, is how reliable right now is the data that's coming in from even from a higher income country like the US? Like, are we right now under reporting antibiotic use? You know, where are we at to what we think is really the total consumption? So go ahead, Libby.
Oh yeah, those are always, those are great questions, always a little difficult, but honestly, you know, sometimes in the lower income countries, there's more mandates and there are great tracking systems at the country level. And sometimes there are disruptions. I know someone asked about what we think about facilities that are located in countries that are at war, have other disruptions. Obviously, that will also disrupt data sources. And so we have to take it with a grain of salt. But time and time again, what we've shown is that sometimes we let perfection be the enemy of progress. And that if we can track, if we can start tracking, and then we can try to validate and refine and improve the data, we will make great strides. And so I think, you know, overall, I've not seen any calculation that shows the data are unreliable. I think the biggest concern is that to get the data, we do allow data from different data sources, which obviously is not comparing apples to apples all the time. And so we just, that's always highlighted when that's there. And I think we just need to be cognizant of that when we're trying to use the data for analysis. Lower AR doesn't necessarily mean it isn't there if there aren't good laboratory systems for tracking it. You know, some of our facilities don't have local laboratories or the ability to do that testing. And so those things all need to be considered. But overall, the systems in place to actually track it are quite robust and ready to accept more when we're ready to send it.
Arjun, what about the US data that, you know, where do you feel that that's at, that's feeding up into the global reporting system, WHO?
Yeah, you know, I mean, it's always challenging. I think what we have in NHSN AU is really the gold standard of how we want antibiotic use data to be collected. We obviously don't have that for every setting. We don't have it for all sectors. So I think we're doing what can be done. I think even the not great data is better than no data at all. And so I think it's one of the things that's really important to continue doing this. You know, I think for too long we let that excuse like, oh, well, we don't have exactly what we want, so we'll just do nothing. So I think it's good. It's providing us a snapshot. It's giving us some basis for comparison, which I think is important and motivating, and it's giving us insights into what's being used by whom and why.
Yeah, I mean, you just think where you started in 2014 to where we're at now.
Yeah, right.
It's tremendous. One of the things that struck me in your presentation is around, you know, you're looking at how many of the core elements have been implemented across these hospitals or these institutions. And one of the ones that seems to be the most difficult or the lowest percentage of it being implemented so far is reporting.
Yeah.
Can you speak a little bit more about that? Is that a resource?
Yeah, you know, I think it's resource intensive, right? Trying to get reports out to people. And, you know, right now, one of the challenges I think is, you know, that's really hard to do, right? You know, getting your antibiotic use data and then being able to create reports to get back to people, that's tough to do. You know, in NHSN, you can do it by unit, but most people like to do it by service line, which we can't do, obviously, in NHSN. So I think that's why, and I think it needs to be an area of focus for us. Like, what can we do in NHSN? What can others do? What are the tools that would be helpful to improve that type of reporting? But I know Libby would probably have thoughts there, because I know this is a huge part of what they do when they're helping hospitals.
Yeah, it's a good question. One of the things we often get asked, or that we provide as a service through DASON here in our US network, you know, is coming and presenting the data. And I think that's part of it, is we have to get comfortable with the questions that will come up from the data, but knowing the data source and knowing comparative data. And I think people often, there are a few questions here about appropriateness, like we've already talked about. I think we have to use the tools that we have. And so we need to be able to drill down and assess. And we showed you that, the US PPS efforts. But in terms of getting that data back and reporting, one, I think honestly, people don't give themselves enough credit. They feel that what they are reporting is not robust enough. I promise you, I was a pharmacy administrator for a few years. And even though we didn't have Nhsn at my hospital or a great antibiotic tracking program, we had reports on antibiotic use because we tracked what we bought. And so starting somewhere is a great place to start. So I think people don't give themselves enough credit on that element. And two, I think it's just building up the comfort level and the confidence in our stewards to go out and talk about that data. You know, turn it around and not just talk about it in your stewardship committee, but bring it back to the groups that are out there. I promise, even surgeons love to see their data. They're very used to it. In fact, when we go, they're at some of my community hospitals, they want to meet with me more than the hospitalist service do, because they really like the real-time feedback in their data. So I think it's one of those processes that we just all have to help each other, and probably just be more, be more accepting of the things we are doing to report our data out.
Libby, well, as far as pharmacy expertise, increased priority for implementation, whether it's ID fellowship, PGY2 residency, or certification program. And Arjun, you mentioned this in your presentation, but for those interested, maybe they can't go back and do an ID fellowship or a residency. Are there certification programs somewhere on your websites?
Yes, there's a great, there are several groups that do this. One of them is the Society of Infectious Diseases Pharmacists that has a program you can enroll in. They're constantly updating it. That includes live interactive webinars. The group that runs MAD-ID has it. We've also seen those several departments of health that are engaging in stewardship work, like Arjun mentioned toward the end of his talk, have started to offer some similar training or mentoring programs as part of state recognition programs. And then especially it's a little bit more community focused, but there is an online course you can take from the CDC that also helps train up in important stewardship elements. And even though admittedly targeting more community, it's a lot of stewardship we can apply in our hospitals as well. And so lots of great places for both the pharmacist and physician stewards to get some of that additional training and the concepts of stewardship if they feel that it's an area they lack.
Yeah. And I think it's important, and obviously we welcome more people taking those certificate programs to help carry out these implementations and get these numbers up, especially in some of these states that are still sub 90%. But having just come through a pandemic, there's been some attrition as well. I know, Libby, you've been tracking that.
Yeah, I find this really sad. And one of the things is we don't have, right at the beginning or early on in the pandemic, there was a great publication actually led by Rochelle Walensky and others, including the IDSA, that looked at the coverage of infectious diseases physicians. We don't yet, but hopefully soon we'll have a similar workforce survey for pharmacists. But one thing we're noticing is that just like infection preventionists, there's data out in that population of professionals that there's a lot of attrition happening, and 40% of their workforce is slated to retire in the next 10 years, but we are not bringing new providers on that quick. Similarly, in infectious diseases, and again, we're waiting for the hard firm numbers to support this, but I know I personally have lost a lot of colleagues who have walked away from infectious diseases or pharmacy altogether just because of the impact of the pandemic. And I think it's something, it is known. And I will say that having been at a few national meetings recently, it is very clear that people are aware of the human resource that is needed to continue fighting and to be prepared for the next pandemic. But I do acknowledge that. So there's a tremendous need for pharmacists to go into this area. Yeah. And hopefully we're generating some interest and can get, there are great training programs out there. There's great opportunities. And so we need to continue to beat the drum and get people in our profession.
Yeah, I think it's important because one of our objectives for this talk was just how these reporting and these data that you're obtaining, Arjun, through your systems and people are changing to their health systems. On the back end of that is also a workforce requirement that you need to continue to, continue to carry out these core elements and continue to get the appropriate reporting and keep people safe with high quality care. So I wanted to ask a question as well. Libby, you just brought it up with the infection preventionists. These data in a way to approach reducing antibiotic use and ultimately reducing antibiotic resistance is you simply can keep people from getting infections in the first place. So infection prevention, maybe decolonization strategies. There's been a lot of, I think a lot of effort and focus on this coming from the CDC, even now engaging with FDA about it. Arjun, how do you intersect these two things? Where there's this antimicrobial steward, but on the very standing shoulder to shoulder is your infection preventionist.
Yeah, absolutely. I mean, those have to be part and parcel and work really closely together. They are both fulfilling really vital functions in the hospital. The goals of stewardship, medication safety, reducing adverse drug events, and of course, reducing that selective pressure in the hopes that you don't create the resistant organisms in the first place. And we know that resistant organisms are going to happen, right? They are going to emerge even if we use antibiotics perfectly. So that's where you have to have infection control, because if one person has it, you don't want everybody to get it. So the efforts, those groups have to work really, really closely together.
Yeah, and Libby, I don't know if you wanted to I just wanted to talk just quickly about that. That's a question that I had personally from some of the presentations I've seen recently.
Yeah, what I will say is, because we've talked so much about reporting here, if you are not a facility reporting your AU into Nhsn, you need to realize you have a tremendous resource in someone in infection prevention at your facility who already knows it. I'll put out a passion plea. Don't go in and try to change their facility structure. Meet with them first. They are experts in this. There are important reasons why they've done what they've done. But honestly, sometimes having to talk about that Nhsn reporting is how I started working more closely with infection preventionists at some of our member hospitals. So they're a great resource, and your challenges are more similar than you realize. And you have data that will help them, and they have data that will help you. Some of these things about tying together resistance data and antibiotic use data, you don't have to wait till that's available. We can start doing that now at the local level, because we have some of these data. I think you'd be surprised at everything that's already tracked and put into Nhsn, and you'll be really impressed with all the hard work they've been doing. So go meet them and get to know what their reporting life looks like. And you'll be surprised at how many collaborations will come from that.
With the few minutes we have just a few minutes left. I'm just going to pause here and let you know that we're going to go ahead and post the attendance code so that all of you will be able to get that code. Elise, that's coordinating the webinar for us, is going ahead and post that. Arjun, both to you and Libby, I want to ask you a final closing question is, where's your focus right now? Give us like the top, one of your top focuses that you're working on for the future in this area.
One, of course, is at a big level, the big picture is driving towards those priority implementation examples. We want to have the stewardship programs continue to move into the more and more effective ways to implement those core elements. At a very tactical level, I think a big focus for us is working on the prescribing of antibiotics for respiratory infections in acute care hospitals. I think COVID has demonstrated there's a lot of potential opportunity for improvement there. We knew that before COVID. We know that treatment of quote community-acquired pneumonia, the #1 indication for antibiotics in acute care hospitals, and we know there's huge room for improvement there. And what I hope to see coming out of the pandemic is providers, I think, increasingly really now do believe that there is such a thing as a viral pneumonia that can cause chest X-ray infiltrates and make fever and make you have a productive cough. And I think people increasingly got COVID was saying, oh yeah, that person has COVID pneumonia. I've done the test, I believe it, and they don't need antibiotics. I think that's a potential kind of springboard moment for us to say, hey, there are other viruses that can do the same thing. So, a lot of places have brought, COVID diagnostics, people have brought flu diagnostics in. There's more respiratory viral panels that are out there. And I think there's an important opportunity to bring those new rapid diagnostics into our approach to how we manage respiratory infections.
Absolutely. Before you start, Libby, seeing the data around viral diagnosis and antibiotic use patterns, you're starting to see more of that data now. So you can't forget about the other, collateral diseases that can affect your antibiotic use. So absolutely good point. And it's also an important point to the importance of diagnostics and the laboratory personnel that may be listening right now. So Libby, where are you focused, or where are you headed to the future?
Gosh, I feel like a lot of different directions, but if we pan back out to sort of the worldwide approach, I think there is a huge shift from a policy standpoint and in other avenues to really take up the One Health approach to combating antibiotic resistance. One question we didn't get to talked about, where is the biggest use of antibiotics? There's a lot, that it's used in animal agriculture and it's used in crop agriculture. And there have been also great advances that we don't have time to go through today in each of those avenues. But I think really combining together so that we all understand what the use cases are for antibiotics and where we might be able to bridge, there are exciting conversations that are starting to happen about use of antibiotics for growth in animals, which is no longer permitted, but actually microbiome manipulation works really well there. And so there might be some lessons from human treatments that we've tried that could meet that need without an antibiotic. So I really think that trying to tie together all the users of antibiotics is going to be an important step from the global perspective to combat AMR. And as well as looking at colleagues who do water and air testing, et cetera, for other pathogens and other sources of resistance. But really, it's only once we're able to back up and look at it from that very large lens will we make the dents we want. But it doesn't mean that we don't continue to do the hard work every day. Like Arjun said at our hospitals, we can't let that big picture get in the way of us saying it still is worth your time to talk about that patient who's been on vancomycin for 8 days. Yeah. It is every single win that together is going to move us down the field on this.
Excellent. We're out of time. But that was a great way to think global, but act local. We appreciate all the efforts of everyone. Certainly appreciate Libby and Arjun's time today. It's been terrific presentations, and the Q&A session was fabulous, and I appreciate everyone that submitted their questions. So go on and have a good day. Share this presentation and all that you've learned with your colleagues so they can go listen to it at a later time. And don't forget to collect your CE, as we all need that to keep our degrees and keep our practices. The attendance code is TG1234, and it's in the chat box. And thank you all.
Thanks, everyone.